including me.
Yes, we'll start. Okay.
Okay, respected teachers, senior IAPNs, friends, and dear postgraduate students, a warm good evening to all. Actually, this is the fourth PG Club organized by IAP Kottayam this year 2024. And first of all, I thank all of you for the participation and support for the smooth conduct of this program by IAP Kottayam. And I would like to welcome the President IAP Kerala, Dr. Shimmi Paulo sir, Mohandas sir, the state coordinator of PG Club, then Anandageshan sir, the scientific coordinator, Dalias madam, our head of the department, and Professor ICH Kottayam, then Marinder sir, President IAP Kottayam, Dr. Sumida, Secretary IAP Kottayam, Dr. Bindu KP, the mentor, Joe sir, Srinivasan sir, Sulfikar sir, and all other senior pediatricians, colleagues, and postgraduate students for this program. And the today's discussion is our own Srilata madam. Madam was at ICH Kottayam for a short tenure as professor, and now she is the professor and head of the Department of Pediatrics, Government Medical College, Alapi, and she is well known for her compassionate and meticulous way with her patients as well as postgraduate students. And we are glad and prestigious to have you again here, madam. And today's case will be presented by our own junior resident, Dr. Divya. Divya, welcome. And okay, I request Mohandas sir to say a few words.
Thank you, Dr. Thomas. It's very happy moment, especially seeing Sulfi sir in this platform after a long gap, and also very senior faculty, Srinivasan sir, Purushothaman sir, for the videos, and I think more than postgraduates, I think faculty are attending this program. And I would like to invite Anandageshan sir to say a few words.
Very good evening, respected state president Dr. Shimmi, program coordinator Mohandas, senior. Very happy to see many seniors, teacher of teachers, our Srinivasan sir, Sulfikar sir, Purushu sir, then Darli madam, then Srilada and all others. Very happy to see a very good crowd and a very good academic people here. So without wasting any time, I hand over to Dr. Mohandas. Jai Hind, Jai Hind.
This session's mentor is Dr. Bindu. I would like to invite Dr. Bindu to introduce today's lead discussant of Srilata. Srilata and myself started post-graduation at the SETI together in 93, and later she moved to Calicut to pursue her MD course. So happy to see Srilata here. I'd like to invite Dr. Bindu to introduce herself. Dr. Bindu. Hello.
I am here, sir. Some problem with net connectivity. I'm here.
Okay. You're audible.
Hello, sir.
You're audible.
Okay. Dr. Divya, our Kera will be presenting a case today, a case of flaccid paralysis. And over to Divya.
Divya, you can start screen sharing, and Srilata, you can.
Divya, you can start presenting.
Srilata, you are muted. Can start the discussion. Okay. And Divya, start presenting.
Okay. Good evening, all. Presenting the case of a 3.5-year-old male child coming from Pathanamthitta. Date of admission is 27/4/2024 and date of examination is 3/5/2024. Informant is mother and the information is reliable. Chief complaints. The child presented with complaints of fever for 5 days duration 2 weeks back and cough for 4 days 2 weeks back with loose stools 1 episode 2 weeks back and difficulty in walking 5 days prior to admission since 22nd of April. History of presenting illness. Apparently normal child presented with complaints of fever for 5 days. It was low grade, intermittent, more during night, and it was associated with cough, which was wet sounding. There was no history of any postural or diurnal variation. It was associated with post-acid vomiting and rhinitis. There was also a history of 1 episode loose stool on the same day. No history of any blood in stool or foul-smelling stools. There was also history of bilateral lower limb pain and low back pain, which was aggravated during the fever spikes, and it was associated with tiredness. The child was taken to the local hospital and was prescribed antibiotics. The symptoms remained the same, and hence they visited another hospital on day 4 and was given some medication, and the symptoms improved. At around 9th day after the onset of fever, mother noticed that the child had difficulty in walking. Child got up from the bed by himself but required the support of surroundings for walking a few steps, after which there was buckling of his knees and he fell down. On next day, 10th day, mother noticed that he was not able to stand up from sitting position. That is, mother required mother to hold him by his shoulders. There was also difficulty in squatting, but he was able to sit up and have food by himself. There is no history of difficulty in lifting his arms while mother helped him to put his shirt on. On day 12, parents took the child to the hospital, during which they noticed that the child was not able to hold his slippers on his feet. They were advised some investigations and sent home. After 2 days, on day 14, mother noticed that the child also had some difficulty in getting up from lying down position, and also she noticed that his legs were flaccid when she carried him, and was immediately taken to local hospital and was referred here. The child was admitted to PICU at the admission, and at admission, the child was not able to sit up by himself. He could not stand or walk, but was able to eat food by himself. There is no history of difficulty in eye movements or drooping of eyelids, no history of deviation of face, or drooling of saliva, or difficulty in eye closing, no history of difficulty in chewing food, no history of change in voice or regurgitation of feeds, no history of difficulty in perceiving pain, touch or cold, touch, hot or cold sensation, no history of difficulty in urination and defecation. He was given an injection for notice that the child was able to get up from lying down position without much difficulty by around 3 to 4 days after admission, and he was able to stand when supported by his shoulders after 5 days. Now the child is able to stand alone for few minutes and can walk with support. There is no history of headache, abnormal movements, altered sensorium, difficulty in speech, no history of excessive cry or irritability on touch, no history of any diurnal variation of symptoms, no history of excessive sweating, excessive redness over the body, no history of trauma, no history of recent vaccination, no history of chronic drug intake, no history of any bites, no history of breathing difficulty. This is the timeline showing the onset of symptom and the course of the symptoms. Past history, history of hospitalization in the past for accidental ingestion of metformin. There is no history of any similar illnesses in the past, no history of any seizure disorder. Natal and postnatal history were uneventful. It was a full-term vaginal delivery. Child cried soon after birth. Birth weight was 2.5 kg. Developmental history, it is normal for age. He can ride tricycle, he can draw circle, and he knows full name. The diet history, he is getting a calorie of 1,167 against an expected of 1,350 calorie, deficit of 183 calories, and protein 17.4 gram excess. Immunization, the child is immunized for age and last vaccinated at 1.5 years of age. Pulse polio immunization taken on January 2024. Family history, he's a second child of non-consanguineous marriage, no history of similar illnesses in family. Socioeconomic history, father is a 40-year-old, studied up till 10th standard, he's working in abroad. Mother 28 years, studied up till 12th standard, she is a tailor, lives in Pakka house, uses well water for drinking and has proper sanitation facilities. They belong to lower middle class family according to the modified Kuppuswamy scale. Summary, 3.5-year-old male child, developmentally normal, immunized for age, admitted with complaints of weakness of bilateral lower limbs, proximal and distal, followed by truncal weakness with history of febrile illness 9 days before the weakness onset. There is no history of bowel or bladder involvement, no sensory system symptoms, no cranial nerve symptoms.
So before going to the examination proper, we'll go back to the history. I'll start from the beginning. It is what were the present complaints, main complaints? Are you all? Am I audible?
Madam, not
audible?
no,
Audible,
madam.
but volume is less.
So what were the presenting complaints?
You are not visible also, madam.
I'm not visible.
Less light. We can see something, but light is not good.
Okay. I'll adjust that. But regarding the audibility,
Audible.
am I audible now?
Yes, yes.
So what are the presenting complaints? What are the important complaints?
Sir, can I interfere for a minute?
Sure, sir.
The first slide shows DOE. So, date of admission and DOE. So, I mistook it for expiry. Later, of course, the child is improving. So, what is DOE means?
Date of
Date of
admission.
examination.
Date of examination.
Examination.
Okay, because the child, the Gillenbury or this thing can also suddenly. So I mistook it. Better don't write it as E. You mention exactly what you meant because misinterpretation can occur, like I had done. Yeah.
Okay, sir.
Okay, Divya, take care. So what are the main complaints?
Main complaints, fever, cough, and loose stools 2 weeks back with difficulty
That is
in
followed
walking,
by difficulty
followed
in
by
walking.
difficulty in walking.
So what are the conditions that we'll consider in this scenario? So the most important complaint is the difficulty in walking.
Yes.
So what all will you consider in this situation? Actually, the presenting complaint to your hospital was difficulty in walking.
Difficult. It can be any viral fever with viral myositis.
Yes, very good. That's one of the most important, most common thing that is usual present with the initially fever, everything subsided within after 1 or 2 days, the child presents with difficulty in walking. Yes. Then
Yeah, following any vaccination,
So vaccination doesn't come to the picture now.
Acute flaccid paralysis. It is most common.
Yes. That AFP എന്ന് പറയുമ്പോൾ ഒരു വളരെ ബ്രോഡ് ആയിട്ടുള്ള ഒരു ഗ്രൂപ്പ് ഓഫ് പ്രോബ്ലംസ് ആണ്. അത് ഏറ്റവും കോമൺ ആയിട്ടുള്ള വൈറൽ മയോസൈറ്റിസ് എന്ന് പറയുമ്പം ഏത് വൈറസ് ആണ് ഏറ്റവും കോമൺ ആയിട്ട് നല്ല സിവിയർ മയോസൈറ്റിസ് so that the patient is unable to walk?
Enterovirus.
ക്ലാസിക്കലി പറയുന്ന ഇൻഫ്ലുവൻസ വൈറസ് ആണ്.
Influenza.
നമ്മൾ നോക്കാം എൻട്രോവൈറസ് യെസ്. Yes. Other conditions, please proceed. Only viral myositis. No other conditions. Yes, come with transverse myelitis. More common than transverse myelitis,
GBS.
Guillain-Barré syndrome. Yeah.
Traumatic
case-
neuritis.
But you were not mentioning about any history of trauma. In this situation, you can consider this motor neuron unit. You started from the muscle, then you can go up. It is conditions that can affect the neuromuscular junction, then the nerves, then the anterior horn cells. Like that, you can go up. Spinal cord, the anterior horn cells.
Cranial causes like Adam.
Yes. UMN, UMN you can consider. Because stroke, very rare bilateral stroke is not so common, but even that it can produce. I mean, your Adam. Then space occupying lesions.
Then
Can ataxia present with a similar similar picture? Ataxia. Many a times
cerebellar.
ataxia. Acute cerebellar.
Post-infectious
ataxia,
cerebellitis.
Yes. Ataxia can also present like this, and you may not be able to differentiate between whether it is lack of coordination or lack of power. Reduced power or no, other coordination problem. At time of presentation, it may be difficult for them. For them, they come with a complaint of difficulty walking. Okay, so that can also be considered. Coming down, problem with the spinal cord. There comes
Spinal
the,
cord.
that is the
Polio. Acute
transverse
poliomyelitis.
myelitis as well as polio. Anterior horn cells. Now it is polio. It's not so common. We consider non-polio enteroviruses can also produce the similar picture. Okay. Then comes the Guillain-Barré syndrome and other conditions which can produce this sort of a weakness. They can produce symmetric, asymmetric. Okay. Then envenomations, you think of envenomations,
Snake bite.
especially when coming from Kottayam, snake bite.
Snake bite.
Yes, neurotoxic. Okay. Yeah, not only cobra, even viper can also
Poisonings.
produce. What is the interval between the bite and the present this weakness, onset of weakness? In case of poisonous envenomations.
A very important point you have mentioned, madam, about snake bite. We had a locked-in syndrome. Child exactly presented this thing without only movement. So I think it's very important to consider, especially in Kerala, which is known for this thing. Thank you.
Thank you. Thank you, sir. So what's the interval between the bite and the onset of weakness? Any idea? It takes maybe it will start within a few minutes. But the usual time is 1 to 10 hours after the bite, the patient can resume. And in that matter, with rate, the local reaction may also be very minimal. Whereas the others can find the bite marks and the local reaction, etc. So this is also important. Then any drugs?
Steroids can cause steroid-induced myopathy.
So that is a very gradual phenomenon.
Lead poisoning.
Yes, lead poisoning and this. Similarly, so many toxic metal poisons. Then
Botulism. Vincristine, amiodarone.
Okay, any porphyria?
Porphyria, acute intermittent porphyria can present as a neuropsychiatric manifestation. Abdominal pain and weakness.
Abdominal pain and weakness.
Weakness.
So this can happen after exposure to many drugs, anticonvulsants, antibiotics, etc. And following the exposure to drugs, not only drugs, they can even after a stressful event, stress, intake of alcohol, etc. They can present with the sudden onset of this weakness. Okay, so in short, there are so many conditions, but when you think of a possibility of a weakness, you have to think from top to bottom. That is a motor unit starting from the UMM, that is the cortex, from down to the muscle. All the possibilities we have to consider. It's what I wanted you to. Yes, talking about vaccines, we'll come to that. Okay, then coming to the next slide. So you was talking that there was a fever. It was a short febrile illness, lasted around 5 days. It appears like a viral infection, right?
Yes.
And after the short febrile illness, the patient started with the pain. What about pain? What is the importance of the pain?
Can be associated viral fever, pain due to viral fever, myalgia, or myositis.
It could be a muscle pain or a neuralgic pain. So both are possible. Okay, so we can consider both. And usually in viral myositis, where is the pain mostly felt? You can have throughout the limb, but
calf muscles.
Yes, very good. It is in the calf muscles. It is predominantly felt. The pain is felt, and the child can refuse to walk. And the usual thing is that they subside within what period of time they usually subside. Any short period, 2-3 days, they completely subside, even though the CPK levels may take more time to subside. Okay, Then, what about the neuralgic pain? What all conditions will you consider? Because you are saying about the pain in the back as well as the lower limbs.
Radicular pain.
Yeah, pain. Where do you get the radicular pain? When something is pressing on the radicals, usually you get that sort of the pain. Spinal cord tumors. You have this neuralgic pain in Guillain-Barré syndrome, as you told. You can have a back pain as well as a lower limb pain. And predominantly back pain, you usually get in the transverse myelitis, you can get it. Okay. Then, is what were you about to say?
Madam.
എന്താ പറഞ്ഞത് ഇപ്പൊ പറഞ്ഞെന്താ
Funicular pain.
Okay, so predominant the pain was very prominent, and after that they noticed the inability to bear weight. Okay, next slide. Next slide. Okay, so you have found that there's a progressively increasing weakness. For how long did it take to reach the worst situation? That is the ladder of the weakness.
On day 14th, after the onset of fever.
But the onset of weakness from when they have known. You consider the
Sixth day of weakness, madam. Sixth day of.
By sixth day of weakness. So suppose it is, we think properly, the most important differential we consider here will be again Guillain-Barré, because that's the most common acute inflammatory neuropathy, peripheral neuropathy. So consider Guillain-Barré. Usually, how long will it take for to reach the maximum at the worst situation of weakness?
2 to 4 weeks.
Yeah, by it won't proceed beyond 4 weeks. But the usual time is that is the median time that they say is 8 days. Usually it is around 8 days. By the second week itself, they reach the worst situation, and this can vary from 5 to 13 days usually. That is the interquartile distance of the പറയാം. അപ്പോൾ ഏറ്റവും കൂടുതൽ അത് ഒരു 5 to 13 days നടക്കാണ് അത് ഏറ്റവും വേഴ്സ്റ്റ് സിറ്റുവേഷനിലേക്ക് വരുന്നത്. And you from the symptomatology, you feel that there was lower limb weakness as well as the trunk weakness, but they haven't noticed any weakness of the upper limbs.
Yes.
Is it so?
Yes, ma'am.
So, what was the degree of disability in this child when it was in the worst situation?
Grade 3, madam.
So scale we'll consider later. Okay. So in the at the ladder of the weakness, the child was unable to sit up. Nothing beyond. No difficulty in using the limbs.
No.
Catching.
He was able to eat food by
himself. He was able to lift his arms. Yes. Okay. So that was the first thing. And after that, there was a plateauing of the situation.
Yes.
Till you started IV immunoglobulin, and after that, child is slowly improving.
Yes.
But that's the history, right?
Yes.
Okay. So here, in short, we have following a possible viral illness. Within a few days, the child has developed an ascending weakness, and that by about 6 days or so, the child was unable to sit up, but were able to use the upper limbs. And there was no, by history wise, there was no evidence of any respiratory impairment. So from history, what all things will you get regarding if there's any respiratory involvement? Because that's the dreaded thing in Guillain-Barré along with the disorder. From history.
Decrease in voice volume, cough reflex, ability to cough,
Mm.
difficulty in swallowing.
Okay. അതൊക്കെയാണ് പ്രൊസീഡിംഗ് ആയിട്ട് വരുന്ന കാര്യങ്ങളാണ് അല്ലെ ഇനബിലിറ്റി ടു ലിഫ്റ്റ് ദ അപ്പർ ലിംസ് ഡിഫിക്കൽട്ടി ഇൻ swallowing following that this respiratory impairment comes in and there was in respiratory complaint ഇതൊക്കെയായിരുന്നു നമുക്ക് ശ്രദ്ധിക്കാൻ പറ്റുന്ന കാണാൻ പറ്റുന്നത് ഹിസ്റ്ററി വൈസ് ആണെങ്കിൽ അപ്പോഴായിരിക്കും സെൻസോറിയം ദോഷമാകുന്നത് അല്ലെ പിന്നെ ഉള്ളത് പിന്നെ വെന്റിലേറ്ററി സപ്പോർട്ടൊക്കെ ഹിസ്റ്ററി ഓഫ് സച്ച് തിങ്സ് ഓക്കെ കൺസിഡർ ദാറ്റ് ഓക്കെ ദെൻ നെക്സ്റ്റ് coming to the past history, what all things we will specifically ask?
History of similar illness in the past.
Similar illness വരുന്ന എപ്പോഴൊക്കെയാണ്
Recurrent GBS.
recurrent GBS. Relapse വരാറുണ്ടോ
CIDP.
പിന്നെ CIDP-ല് ആദ്യം ഒരു സ്ലോ കോഴ്സ് വന്നിട്ട് പിന്നെ വീണ്ടും റിലാപ്സ് ചെയ്ത് കൊടുക്കാം അങ്ങനത്തെ ഒരു ഹിസ്റ്ററി വരണം ഒരു മോണോഫേസിക് ഇൽനസ് പോലെ വന്നിട്ട് പിന്നെ അത് റിലാപ്സ് ചെയ്തിട്ട് കണ്ടിന്യൂ ചെയ്യും ഓക്കെ
Periodic paralysis.
Yes, very good. Periodic paralysis. Then this porphyria again recurrent you can get. In coming to the upper neuronic lesions, you can get not like this symmetrical, but not bilateral weakness, but alternating hemiplegia, hemiplegic migraine, etc. A weakness you can get recurrent in different manner. Then you should also have mentioned about the vaccinations. Any vaccinations which can lead on to even Guillain-Barré.
Rabies vaccination.
Very good. Rabies, that's a very common vaccine that can produce Guillain-Barré. Then
Influenza.
Rarely, not so common. Then
OPV.
COVID vaccine. COVID vaccine. A lot of controversies are there. So COVID vaccine is another vaccine. So vaccine. Similarly, you can ask about the drugs we have already mentioned. So those are the things you have to then any then tick bites ഉണ്ടല്ലോ tick bites sandy areas tick bites tick paralysis എന്ന് പറഞ്ഞിട്ട് ഉണ്ടല്ലോ tick bites engorged ആയിട്ടുള്ള കാലെന്നൊക്കെ തട്ടിക്കളഞ്ഞു എന്നൊക്കെ പറഞ്ഞിട്ടുള്ള ഒരു ഹിസ്റ്ററി ഒക്കെ then next slide. Next.
Not audible.
ദാസ്
Hello, madam.
മാഡം ഇല്ലയോ ഓൺലൈൻ ഇല്ലേ ദാസ് മാഡം ഈസ് ഔട്ട്
Srilata is out.
Divya, in this case, when you get it's a 3.5-year-old child. So when you present, you always keep in mind what all things the child will reveal about that problem always. So rather than telling a list of no and all the conditions, always consider that as a 3.5-year-old child, when she is complaining about on subjective complaints. Okay. So a 3.5-year-old child, the problems the mother or the parents reveal is different. And you are expressing the subjective complaints, consider that that's a 3.5-year-old child. Okay. Then when you're presenting the complaint in the first part, the history of presenting illness, presenting complaint, the presentation should be careful. The problem started, you examine on the 3rd of the May, the problem started on 27th. You said 2 weeks of problems, fever, loose stools. And then you are coming back to this problem started on 21st. So that should not be that you're creating problems. Always the onset of the illness and each of this should be in sequence and going forwards rather than mixing up. So on which date the loose stool started with the fever, and on the 6th day or 7th day, this weakness started, like that you should be moving on. Rather than mixing up the dates, that will be creating confusion. So whenever you are getting a problems like this, any problem, you need to sequentially answer, is there a neurological problem? Where is the problem? And what is a pathological basis? Rather than going into the disease entities. So first of all, as madam said, what exactly is the problem? Is it a problem of the balance? Is it a weakness? In this case, if you think answer, it's not a problem of balance, it's the weakness. Then second thing is it a pseudo paralysis? So is there a neurological problem or some other thing which look like neurological also need to be considered in a young child? Pseudo paralysis situations need to consider. Then that also is answered no. Then sequentially you bring out it is a central spinal cord motor unit. Okay. So in this case, all the points are not for entities, but where is the lesion? Okay. So you have mentioned there is nothing suggesting of a central cause. Then spinal cord, there is no bowel bladder disturbance. The patient's sensations are normal. So all these points you are bringing down to the lower level. It's likely to be a motor unit problem, and rarely spinal cord also can present without a bowel bladder disturbance because a patchy involvement of spinal cord cannot be ruled out. So that is the way, anatomical localization first, then only you go for the pathological basis and disease entities. Of course, there comes the onset and progression of the illness. Was it a abrupt onset, gradual onset? Because following diarrhea, there can be a vascular phenomenon like anterior spinal artery compression, occlusion, trauma. All these things also need to be considered. So in this case, that should be approach. Really, let's come back. One no.
ഇല്ല ഇടയിൽ വന്നിട്ട് പിന്നെയും പോയി.
ആണോ കണക്ഷൻ്റെ എന്തോ ഇഷ്യൂ ഉണ്ട് അവിടെ. So that should be the always anatomical localization points and the history need to consider. Then only go for the different entities. So I hope this child was 3.5-year-old boy child or girl child?
Boy child.
Boy child, perfectly all right child up to this. Okay, in summary, perfectly all right child, developmental milestones, everything acquired and perfectly healthy child following a loose stool. On the 6th day, they started having weakness more in the lower limb only. It's bilaterally symmetric. Both limbs are inborn, upper limb spared, and no problems in the cranial nerve territory without any sensory problems, any bowel bladder disorders. Not much of fever, not much of pain. Okay. So that is the context. So what all possibility you consider and what are the what all things in the examination finding. That's how you proceed. Okay. A similar case was discussed earlier. That's why you are not too much of discussing repetition. Okay. Silada is the, if she is there, you can move forward, I think. Okay. Dasa, can we move forward without waiting?
We will, we can continue it, sir. Dr. Thomas, can you call Srilata?
Silada is there?
സാറേ വിളിക്കാം, ഞാൻ വിളിക്കാം സാറേ, ഞാൻ വിളിക്കാം.
ഒന്ന് വിളിച്ചു നോക്കൂ,
ഓക്കെ,
ജനറൽ എക്സാമിനേഷന് മുമ്പേ.
നോക്കട്ടെ.
Is back. Okay, you take over. Move on.
Sorry for the injection. So, you can proceed. Proceed.
Hello.
Dr. Divya, you can continue your presentation.
Okay, sir.
മാഡം ഉണ്ട് ദിവ്യ, കണ്ടിന്യൂ ചെയ്തോ.
General examination. Child was alert, comfortable with mother, obeys commands, interested in surroundings, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Vitals, pulse rate 100 per minute, regular rhythm, normal in volume, all peripheral pulses felt equally bilaterally, no radial or radiofemoral delay. BP 90/58 millimeters of mercury, right upper arm, supine position. Respiratory rate 24 per minute, normal breathing pattern. Saturation 100% room air. Temperature 98.6 degrees Fahrenheit. Head to foot examination. Head appears normal in size, no gross dysmorphism. Eyes normal, no neurocutaneous markers, no scars, white marks, rashes or nail changes. Anthropometry, weight 12.5 kg. Expected was 15 kg, between 0 and -2 standard deviation normal. Height 96 centimeter, 100 expected 100 centimeter, between 0 and -2 standard deviation normal. Head circumference 48.5 centimeter, expected 50 centimeter, between 0 and -1 standard deviation. Mid upper arm circumference 14 centimeters normal. System examination. Now a system examination. Higher mental function. Child is well groomed, aware, alert, has reasonable interest in surroundings and is cooperative for examination. His behavior is reasonably appropriate for the situation and has normal speech. Cranial nerve examination. Olfactory nerve not tested. Optic nerve. Bilateral pupils equally reactive to both direct and indirect light reflex. Visual acuity identifies familiar objects when shown. Color vision identifies red and yellow color. Fundus normal. Oculomotor, trochlear and abducens nerve. No ptosis, nystagmus or squint. Extraocular movements full. Trigeminal nerve. Movements of jaw normal. Jaw absent. Bilateral corneal reflex present. Facial nerve. Wrinkling of forehead, symmetrical bilaterally. Eye closure complete on both sides. Nasolabial fold maintained. No deviation of angle of mouth. Blowing of cheeks normal. Sensation over anterior 2/3 of tongue not assessed. Vestibulocochlear nerve. When called by name, he turns to head to that side. Glossopharyngeal and vagus. Uvula in the midline. Palatal movements bilaterally symmetrical. No regurgitation or cooling of secretions. Spinal accessory. Turning of head to the sides against resistance present. Shrugging of shoulders present. Hypoglossal. No deviation of tongue on protrusion. No tongue fasciculations. Motor system examination. Bulk. Upper and lower limb normal. Tone decreased in both upper and lower limb. Gait not able to stand, hence could not be assessed. Power. Neck flexion and extension 5/5 normal. Upper limb, shoulder, abduction, adduction, flexion, extension, both right and left 4/5. elbow flexion and extension 4/5, wrist extension and flexion 4/5. Finger grip was slightly more, hence 4 plus. Lower limb, hip flexion extension, adduction and abduction 3/5, both right and left. Knee flexion extension 3/5. Ankle plantar flexion 4/5, right and left. Dorsiflexion 3/5. Reflexes, superficial reflex, corneal and conjunctival reflex present, abdominal reflex absent, cremasteric reflex present, diminished, plantar reflex, bilateral flexor. Deep tendon reflexes, biceps jerk, 1 plus on right and left, triceps and supinator jerk 1 plus on both right and left, knee jerk and ankle jerk absent. Sensory system responds by withdrawing the limb when given painful stimuli, can identify hot and cold sensations. No cerebellar signs, no signs of meningeal irritations, skull and spine normal. Other systems with a normal limit. Summary. 3.5-year-old male child, developmentally normal, immunized for age, admitted with complaints of weakness of bilateral lower limbs, proximal and distal, followed by truncal weakness with history of febrile illness 9 days before the onset of weakness. On examination, flaccid motor weakness with power of grade 3 in lower limbs and grade 4 in upper limbs, with diminished deep tendon reflexes in upper limb and absent lower limb reflexes. Plantar bilateral flexor. There is no bulbar, respiratory or extraocular muscle weakness. No involvement of higher mental function, cranial nerve, sensory system and urinary bladder. Other systems within normal limit. Diagnosis. Madam,
You are muted. You are muted.
Yes, sorry. Yes. You can proceed.
diagnosis. Can I proceed, madam?
Yes, proceed.
Diagnosis: acute flaccid paralysis, ascending symmetric paralysis with areflexia in lower limbs and diminished reflexes in upper limb. No bladder or bowel involvement. Neuroanatomical side, probably lower motor neuron, peripheral nerve. Etiology, demyelination. Immunized for age, developmentally normal, nutrition normal.
First of all, talking about the sensory infection.
Hello.
First of all, regarding the sensory infection. When you get a child, you have some
Madam, not audible, madam.
not audible. Not audible.
Now audible.
So when you consider a child who has a it could be Guillain-Barré syndrome, after possible weakness, child possible with a weakness, what are the things in the sensor for things from normal sensorium?
Sorry, madam. It's not
Not
clear.
Srilata, it's not clear.
Okay, now audible now?
Yes, madam.
Audible?
Yes, madam.
So in this sort of a scenario, if the child is an altered sensorium, what all things will you suspect? An altered sensorium.
Upper motor neuron lesion.
Yes, definitely. For motor neuron function. This is the lower motor.
Madam, audio is not clear, madam.
Suppose it's a can it be a low stage be a lower motor neuron lesion? Next will be a low motor neuron lesion. Will come off. Will come off. Can it still be a locomotor neuron lesion? Can it still be a locomotor neuron lesion?
Yes, ma'am.
Vidya?
Madam.
Vidya?
Yes, ma'am.
Audible അല്ലേ ഞാൻ audible അല്ലേ
Not clear.
There's a problem with Dr. Srida's audio, I think, when she came back. Divya,
Yes,
at the examination stage, always you need to consider the previous history part also. I was looking at your anthropometric measures and your dietetic history. According to you, in your data, it was said 17 grams of protein intake higher than expected. There was only 150 calorie deficit. Actual intake was very good. Okay. Intake calorie, there is only 150, 180 deficit. There is 17 grams of excess of protein. And when you came to the measurement, what is the measurement? 12.5 kg less than expected. Okay. So that won't go together. So you need to revise always. Always go back. It should be correlating. Okay. Next one, in a 3.5-year-old child, why you said expected is 100 and 96 is inadequate? What is the classical teaching? Maybe in your reference this thing and all. But 4 years 100, that's what you learn. 96 is inadequate. Always you need to consider these parameters. And in the examination, what about the power in the upper and lower limbs? Till now, your weakness was only in the lower territory and there was a minimal weakness of sitting up. After that, there was no mention of power problem in the upper trunk, neck holding, cranial nerve territory and the upper limb. Okay. From here onwards, you mentioned there is 4/5 in all the group of in the upper limb. So is there any problem with your assessment? When you're assessing a 3.5-year-old child, give allowance for that power, especially when you think upper limb are not affected clinically. So otherwise, what will happen? According to you now, the weakness is there in the upper limb also, which was not there in the history. So history and your examination is not correlating. So there is a weakness in both upper limb when you're telling that there is 4/5 power in proximal, distal, everywhere. Is there a power problem in the upper limb? In the reflexes also, upper limb reflexes are normal and you are getting a reflex absence in the knee and the ankle. So whenever you are moving forward with the finding, it should be correlating with whatever you are telling in the previous slides presentation. Otherwise, you'll be finding it difficult to explain. Okay. And the vessel examination, the pulse volume, rhythm, all these things are important. Sridhar has come back.
Yes, sir.
Okay,
Am I audible now? Am I audible now?
Now clear. Now clear. You go ahead.
Okay. So I was asking, suppose the child's sensorium was dull. So if he was appearing to be still a little bit drowsy, you would have thought about an UMN lesion. Even will you consider then also LMN lesion? if at all, you were considering a Guillain-Barré syndrome, and then you found that this child is drowsy, what will you think of now then? Immediately, what will you look? Venkat. Venkat.
Madam, features of encephalopathy,
Eda?
pupils,
Yes.
and features of encephalopathy, like
Cephalopathy. No, you have diagnosed a child be having GBS, and you are seeing it daily, and during the round, found that this child is drowsy. What will you think of?
any respiratory
Yes, respiratory
drive,
pain.
poor respiratory drive,
Immediately look at the breathing pattern. You should look at the SpO2, all these things. Okay, this is another thing. And regarding the vitals, what are all important in a child in whom you are suspecting GBS? Vitals. One, we have already discussed the respiration. Respiratory coming down.
Pulse rate,
Then
BP,
പൾസിൽ എന്തൊക്കെയാണ് നോക്കുന്നത്?
tachycardia or bradycardia.
Yes, good. Then
BP, postural hypotension.
Postural hypotension as well as hypertension. Both you can have. Okay. So when you are recording all these things, you should mention it's not there like that. Okay. Then you were talking about sir was also mentioning about that power. Assessing power in a 3-year or 3.5 in a toddler or a preschool child is really difficult. So we limit ourselves to certain groups of muscles so that we can have an assessment of the entire segments. Okay. So you in the upper limb, you look the shoulder abduction, right? Not the other internal rotation, external. ദിവ്യക്ക് അത് ചെയ്യാൻ പറ്റിയിട്ടുണ്ടായിരുന്നോ? ഇന്റേണൽ റൊട്ടേഷൻ ഓഫ് ദ ഷോൾഡർ, എക്സ്റ്റേണൽ റൊട്ടേഷൻ ഒക്കെ. അബ്ഡക്ഷൻ മാത്രമേ ചെയ്യാൻ പറ്റൂ. അഡക്ഷനും ഒക്കെ ചെയ്യാൻ വലിയ ബുദ്ധിമുട്ടാ. ഓക്കെ, അപ്പോ നമ്മൾ കുറച്ച് ലിമിറ്റഡ് മാത്രം ചെയ്താൽ മതിയാകും. സോ ദാറ്റ് ഇനഫ്, ദാറ്റ് വിൽ ഗിവ് a good idea about the various segments of the spinal cord segments. അപ്പോ നമ്മൾ സാധാരണ നോക്കുന്നതെന്ന് പറഞ്ഞാൽ അപ്പർ ലിംബിൽ വരുമ്പോൾ ഷോൾഡറിലെ അബ്ഡക്ഷൻ, എൽബോ ഫ്ലെക്ഷൻ, റിസ്റ്റിന്റെ എക്സ്റ്റൻഷൻ, ദെൻ ഗ്രിപ്പ്, ഹാൻഡ് ഗ്രിപ്പ്. ഇത്രയും ചെയ്താൽ തന്നെ നമുക്ക് ഫുൾ, അതായത് C1 തൊഴിൽ T1 വരെയുള്ള ഒരു ഐഡിയ കിട്ടും. ഓക്കെ, അതുപോലെ തന്നെ ലോവർ ലിംബിലാണെങ്കിൽ ഹിപ്പിലെ ഫ്ലെക്ഷൻ, നീൽ എക്സ്റ്റൻഷൻ, ഡോസി ഫ്ലെക്ഷൻ ആൻഡ് പ്ലാന്റാർ ഫ്ലെക്ഷൻ. റൈറ്റ്?
ഓക്കെ മാഡം.
ഇത്രയും കാര്യങ്ങൾ നമുക്ക് നോക്കാൻ പറ്റുള്ളൂ. അത്രയും നോക്കിയാൽ തന്നെയും നമുക്ക് ഒരു L2 മുതൽ താഴോട്ട് S1 വരെയുള്ള മസിൽ ഗ്രൂപ്പ്സിന്റെ സെഗ്മെന്റ്സിന്റെ പവർ, അതിന്റെ സപ്ലൈ ചെയ്യുന്ന മസിൽസിന്റെ പവർ അസസ് ചെയ്യാൻ പറ്റും. അല്ല നമുക്ക് ഈ ഹിപ്പിന്റെ എക്സ്റ്റൻഷൻ, പിന്നെ നീഡ് ഫ്ലെക്ഷൻ, ഇതൊക്കെ ചെയ്യാൻ വലിയ ബുദ്ധിമുട്ടാണ് കുട്ടികൾക്ക്. അപ്പൊ നിങ്ങളിത് ചെയ്തു എന്ന് പറയുമ്പോൾ തന്നെ അറിയാം ഇതൊന്നും ചെയ്തിട്ടില്ല എന്ന്. ഇതൊന്നും ഡോണ്ട് വെഞ്ചർ അപ്പോൺ സച്ച് തിങ്സ്. ഓക്കെ. അതെ, പിന്നെ സാറ് ഓൾറെഡി പറഞ്ഞു കഴിഞ്ഞു ഈ അപ്പർ ലിംബിന്റെ ഭയങ്കര പെട്ടെന്നൊരു വ്യത്യാസം വരുന്നത്. നിങ്ങളുടെ ഇതനുസരിച്ച് എന്ന് പറഞ്ഞാൽ ശരിക്കും അപ്പർ ലിംബ് വലിയ അഫക്റ്റഡ് അല്ല എന്നുള്ള രീതിയിലാണ്. ഓക്കെ, പിന്നെ cranial nerves, especially in this case, which are the other conditions, LMN conditions, പിന്നെ cranial nerves affected ആണ്. Guillain-Barré cranial nerves affected ആകാമോ?
Facial nerve can be affected.
Ah.
Miller-Fisher variant.
No.
Extra. ocular muscles involvement.
ഇത് മാത്രമല്ല ബാക്കിയുള്ള ക്രീനിയൽ നെർവ്സ് ഒക്കെ അഫക്റ്റഡ് ആകാം. ഗില്ലൻ ബാരിയിൽ ഏറ്റവും കോമൺ ഫേഷ്യൽ നെർവ് ആണെന്നേ ഉള്ളൂ. മില്ലർ ഫിഷർ തന്നെ ആവണമെന്നില്ല. ഓക്കെ, ദെൻ വേറെ ഏതെങ്കിലും ഈ LMN ഇതില് നമ്മള് ഈ ക്രീനിയൽ നെർവ്സ് പ്രാധാന്യം കൊടുക്കുന്നുണ്ടോ?
9, 10.
9, 10 ഗില്ലൻ ബാരിയിൽ തന്നെ അഫക്റ്റഡ് ആകാം അല്ലെ? പിന്നെ ബോട്ടുലിസ് അതിനകത്തൊക്കെ വരോ? ഡിഫ്തെറിറ്റിക് പരാൽസ്, ഐ മീൻ
Bulbar palsy.
സ്നേക്ക് എൻവെനമേഷൻ അതിനകത്ത് പറ്റില്ലേ? ടോസിസ്,
വരും.
ഒഫ്താൽമോപ്ലീജിയ അല്ലെ?
Yes.
കഴിഞ്ഞ താഴോട്ട് ഡിസാർട്രിയ അങ്ങനെ അങ്ങനെ വന്നുകൊണ്ടിരിക്കുന്ന താഴോട്ട് അല്ലെ? ഒരു ഡിസെൻഡിങ് സോർട്ട് ഓഫ് പരാലിസിസ്. പിന്നെ ബോട്ടലിസ്റ്റില്, മൈസ്തീനിയയില് ഒക്കെ ആണെങ്കിൽ എക്സ്ട്രാക്കുലർ മസിൽസ് ഒക്കെ അഫക്റ്റഡ് ആകും. സോ അത് ഓരോന്നും നോക്കുന്ന എന്തിനാണ് എന്നുള്ള നമുക്ക് എപ്പോഴും ഒരു ഐഡിയ ഉണ്ടാവണം. ഓക്കെ, so coming to your diagnosis, we'll come to your diagnosis.
Hear anything, Sundara, you are muted.
So you have an acute flaccid paralysis. We have weakness, hypotonia, and areflexia. And this is of a short duration. So definitely it is an AFP. And it is an ascending type. And the most common condition is the Guillain-Barré syndrome. So what are your differential diagnosis? Your differential?
Poliomyelitis.
Okay.
Transverse myelitis.
Transverse myelitis അതിന് points in favor against എന്തൊക്കെയാണ്?
Definite sensory level is not there.
Is it possible to get it? Is it possible to get it in a very young child? നമുക്ക് definite sensory levels ഒക്കെ കണ്ടുപിടിക്കാൻ ബുദ്ധിമുട്ടല്ലേ?
Yes, ma'am.
വേറെ എന്തൊക്കെ പോയിന്റ്സ് ആണ് ആയിട്ടുള്ളത്?
Bowel and bladder involvement.
ബ്ലാഡർ ഇൻവോൾവ്മെന്റ്. ഗില്ലൻ-ബാരിയിൽ എങ്ങനെയാ ബ്ലാഡർ ഇൻവോൾവ്മെന്റ് ഒക്കെ വരുമോ?
Can be transient.
They can may be present, but it is only very transient. If you have a persistent bladder involvement, it's a point against a Guillain-Barré. Then, where you don't suspect any, not ഒരു significant sensory involvement. അതായത് ലോസ് ഓഫ് സെൻസേഷൻ ആയിട്ട് നിങ്ങൾക്ക് ഡെമോൺസ്ട്രേറ്റ് ചെയ്യാൻ പറ്റിയിട്ടില്ല. സോ ദാറ്റ് ഇസ് ഓൾസോ അനദർ പോയിന്റ് അഗൈൻസ്റ്റ് ഇറ്റ്. ആൻഡ് ഓൾസോ യു ഗെറ്റ് now it's so many days after the onset of the illness അല്ലെ? ട്രാൻസ്വേഴ്സ് മൈലൈറ്റിസ് ആണെങ്കിലോ by this time you get hyperreflexia and extensive plantar ഒക്കെ വരേണ്ട സമയമായി. So that is regarding transverse myelitis. വേറെ
Viral myositis.
Viral myositis.
Poliomyelitis.
Poliomyelitis. Anything against polio?
weakness onset along with fever.
Mm.
In poliomyelitis, it will be fever will be along with the onset of weakness.
Mm.
Then symmetric patchy involvement will
It is an
asymmetric patchy involvement.
Okay.
Asymmetric.
Mm. Okay. ലോവ് ലിംബാണോ അപ്പർ ലിംബാണോ കൂടുതൽ എഫക്റ്റഡ് ആവുന്ന നമുക്ക് കൂടുതലൊന്നും അറിയില്ല അല്ലെ, നമ്മളൊക്കെ പോളിയോ കേസസ് ഒന്നും അങ്ങനെ കണ്ടിട്ടില്ല. ലോവർ limb is more affected than the upper limb. That's what is described. Okay. But the child is a fully immunized child, getting injectable polio as well as oral polio എല്ലാം കിട്ടിയ ഒരു കുട്ടിയാണ്. അപ്പൊ സാധ്യത കുറവാണ്. More than a polio, we'll consider non-polio enteroviral infection. It's a possibility. Okay. But here we have asymmetric, it is a symmetric paralysis. So those are all against it. Okay. Then, വേറെ എന്തെങ്കിലും ഡിഫറൻഷ്യൽസ് ഉണ്ടോ?
Myopathy.
Muscle disease. You think in terms of muscle disease? അത് തന്നെ ഇത്ര എക്സ്റ്റെൻസീവ് പെട്ടെന്ന് എസ്പെഷ്യലി പെയിനും ഒക്കെ ആയിട്ട് വരാവുന്ന ഏതാ? പോളിമയോസൈറ്റിസ് അല്ലെ, കുറച്ച് നല്ല സിവിയർ പെയിൻ ആയിട്ടും ടോട്ടലി കുട്ടി നടക്കാൻ പറ്റാത്ത രീതിയിൽ ആകാം, അത്രയ്ക്കും പെയിൻഫുൾ ആയിട്ടുള്ള ഒരു സിറ്റുവേഷൻ ആയിട്ട് പോളിമയോസൈറ്റിസ്. പക്ഷെ പെട്ടെന്ന് റിക്കവർ ഒന്നും ചെയ്യാറില്ല. ഓക്കെ, സോ ഇറ്റ്സ് എ ലോങ് സ്റ്റാൻഡിങ് പ്രോബ്ലം, ഗോസ് ഇൻ ടു എ ലോങ് സ്റ്റാൻഡിങ് പ്രോബ്ലം. ഓക്കെ. Okay, so now how will you proceed?
Investigations. CBC, total count was normal. CRP 0.4. Serum electrolytes, sodium 138, potassium 4.5, CPK 61.
How do the electrolytes keep important in this, in a child presenting with acute weakness?
Hypokalemic periodic paralysis.
Even without a periodic paralysis, hypokalemia itself can present this total weakness. Where electrolyte disturbances occur, ഇതേപോലെ total weakness പോലെ present ചെയ്യാവുന്ന hypocalcemia, hypophosphatemia, hyponatremia, all these can present with a generalized weakness. Right. Okay. Then rest of the investigations.
MRI was done, brain and spine. It was normal with no evidence of demyelination.
എന്തിനാ MRI ബ്രെയിനും സ്പൈനും ചെയ്തത്? What were you expecting in it?
In GBS, there may be root enhancement.
നമ്മള് എൻഹാൻസ്മെന്റ് പറഞ്ഞെങ്കിൽ കോൺട്രാസ്റ്റ് ഇടണ്ടേ? കോൺട്രാസ്റ്റ് ആണോ? നമ്മൾ കോൺട്രാസ്റ്റ് കൊടുക്കുമ്പോഴാണ്, അങ്ങനെയല്ലേ? കോൺട്രാസ്റ്റ് കൊടുക്കുമ്പോഴാണ് റൂട്ട് എൻഹാൻസ്മെന്റ്, കോഡൈക്വൈനൈഡോട് എൻഹാൻസ്മെന്റ് ഒക്കെ കിട്ടുന്നത്. ഓക്കെ. Okay, again, transverse myelitis, then infective myelitis, then tumors, spinal cord tumors. All these can be excluded by your imaging study. Okay, imaging is over. Then next.
CSF study.
Hello.
Showed protein of 153 milligram per deciliter.
When
Total
was
counts.
When was this done? CSF study, when was it done? How many days
Onset.
after the onset of the illness? How many days after the onset of illness was the CSO study done?
10 days.
10 days. Not the onset of fever.
Yes, madam. Weakness. After the onset of weakness.
Weakness തുടങ്ങി 10 ദിവസമായപ്പോഴാ ചെയ്തത്. That is during the second week you have done this, right?
Yes.
Okay. Right?
Yes.
Suppose you have a very high CSF protein. And importance എന്താണ്? എന്തെങ്കിലും relevance ഉണ്ടോ അതിന്? More than 800 എന്നൊക്കെ പറഞ്ഞാല് higher protein values എന്ന് പറഞ്ഞാല് recovery slow ആയിരിക്കും, incomplete recoveryക്കുള്ള സാധ്യത കൂടുതലാണ് എന്നൊക്കെയുള്ള കാണിക്കും. അതാണ് CSF പ്രോട്ടീന്റെ വേറൊരു ഇമ്പോർട്ടൻസ്. Okay, coming to the next investigation.
Now conduction study.
Now conduction study എന്ത് കിട്ടി?
Latency was prolonged in bilateral, median, ulnar, deep peroneal, tibial, and femoral with decreased compound muscle action potential in all the above nerves. Velocity was decreased.
കണ്ടക്ഷൻ വെലോസിറ്റി നന്നായിട്ട് കുറഞ്ഞിട്ടുണ്ട് അല്ലെ? നോർമലി ഒരു 40-50 അല്ലേ നിൽക്കുന്ന അപ്പർ ലിംബില്, താഴെ ഒരു 40യോ. ഇത് ഒത്തിരി കൺസിഡറബിളി റെഡ്യൂസ്ഡ് ആണ് കണ്ടക്ഷൻ വെലോസിറ്റി. ആൻഡ് വാട്ട് അബൌട്ട് ദ ആംപ്ലിറ്റ്യൂഡ്? ആംപ്ലിറ്റ്യൂഡും കുറച്ച് കുറവാണ് അല്ലെ? പിന്നെ എഫ് വേവിന് അതല്ലേ നോക്കുന്ന അടുത്ത ഇപ്പുറത്തെ റൈറ്റ് സൈഡിൽ എഫ് വേവ് അല്ലെ? ഇറ്റ് ഇസ് നോട്ട് ഒബ്റ്റെയിൻഡ് അല്ലെ? എഫ് വേവ് ഉണ്ടോ? ഇല്ല. എഫ് വേവ് ആണ് കുറച്ചുകൂടെ ഇമ്പോർട്ടന്റ് ആയിട്ട്. അതായത് റാഡിക്കൽ, അതായത് റൂട്ട്സിന് നമ്മൾ അസസ് ചെയ്യുമ്പോൾ നമ്മൾ നോക്കുന്ന എഫ് വേവ് ആണ്. എന്താണ് ഈ എഫ് വേവ് എന്ന് പറഞ്ഞാല്? When do you get it? Gopi is there? Yes. What is this F wave? You're talking so much, very much about the F wave when you're considering Guillain-Barré. F wave എന്താണ്?
motor conduction velocity.
മോട്ടോർ കണ്ടക്ഷൻ വെലോസിറ്റി ആണോ നോക്കുന്നത്? എന്താ പറ്റുന്ന അതിനകത്ത്? When you're stimulating a motor nerve, എന്താ പറ്റുന്ന?
Stimulate ചെയ്തിട്ട് അതിന്റെ ആംപ്ലിറ്റ്യൂഡ്.
So when you give a stimulation to a nerve, it proceeds distally as well as a little or proximally also. Antidromic. അപ്പോ അങ്ങനെ പോകുന്ന ഇമ്പൾസസ് നമ്മുടെ ആന്റീരിയർ ഹോൺ സെല്ലിൽ ചെന്നിട്ട് അവിടെ ഒരു അതിനെ സ്റ്റിമുലേറ്റ് ചെയ്യും. അപ്പൊ അവിടുന്ന് പുതിയ ഒരു ഇമ്പൾസ്, സോ യു ഗെറ്റ് ഡിലേഡ് ആയിട്ട് വീണ്ടും ഒരു മസിൽ കൺട്രാക്ഷൻ ഉണ്ടാകും. ഓക്കെ, അപ്പോ ഒരു പുതിയ പൊട്ടൻഷ്യൽ ഉണ്ടാകും. അപ്പൊ അതിനെയാണ് നമ്മൾ എഫ് വേവ് എന്ന് പറയുന്നത്. അപ്പൊ പ്രോക്സിമലി പോകുമ്പം അവിടെ ഡീമൈലേറ്റഡ് ആണെങ്കിൽ യു ഡോണ്ട് ഗെറ്റ് ദിസ് വേവ്. And that's why this Guillain-Barré, this is absent. Right? Is it clear?
Yes, ma'am.
Okay. So the electrophysiological studies are very much suggestive of demyelination along with some amount of axonal involvement also. About the sensory nerves affect ചെയ്യുന്നുണ്ട് അല്ലെ? So നിങ്ങൾ ഇതിനപ്പം ഗില്ലൻ-ബാരിയുടെ ഏത് വേരിയന്റ് ആയിട്ടാണ് നോക്കുന്നത്? AIDP ആണോ, അംസാൻ ആണോ, അമാൻ ആണോ, ഏതാണ്? അംസാനെ പോലെയാണ് അല്ലെ ഇരിക്കുന്നത്. ബിക്കോസ് ഇറ്റ് ഈസ് നോട്ട് ഓൺലി showing features of demyelination but also features of some amount of axonal involvement also, and also that is it's not only a purely motor involvement, it is affecting the sensory nerves also. Okay, so generally it is literature says that pure AIDP is seen mostly in the developed countries and countries like Asia. It is more common will be the axonal type of involvement. That is Aman, Amsan, etc. So how is it different from the other one, AIDP?
AIDP, it is demyelinating.
So outcome. We are worried about outcome. Any difference? In Aman, there is not a sensory involvement is absent, almost sensory symptoms are less. Whereas in Amsan, there is also sensory involvement is also there. Regarding recovery, slower.
Axonal has slower recovery.
Recovery is slower than that of AIDP. Okay. So how are you going to manage this child?
Supportive management.
So before going to that, Gillenbarry disability scale എങ്ങനെയാണ് അത് പറയുന്ന disability scale ഉണ്ടല്ലോ. So we assess how much disability this child is. അതിനൊരു സ്കെയിൽ ഇല്ലേ?
Yes, madam. Huge disability score.
Huge. അപ്പൊ അതൊന്ന് പറഞ്ഞേ.
0.
അതായത് കുട്ടിയെ ഫോളോ ചെയ്യുമ്പോൾ ഇംപ്രൂവ്മെന്റ് എത്രയാന്ന് അറിയാൻ നമുക്ക് ഈ സ്കെയിലിംഗ് സഹായിക്കും. അപ്പം അതനുസരിച്ച് എങ്ങനെയാ ഈ സ്കെയില്?
0, it is healthy state. Then 1, there is minor symptoms. 2, there is the child can walk.
Minor symptoms, child can run അല്ലേ? ഒരു മിനിമൽ ഡിസബിലിറ്റിയേ ഉള്ളൂ. Child is able to run also.
Yes.
1. 2 is?
2 is can walk more than 10 meters with but cannot run.
Without support ആണ് 10 meter വരെ നടക്കാൻ പറ്റും, പക്ഷേ is unable to run.
Then 3, it is child can walk 10 meters with support only in an open space.
Okay, good. Then
4, there is wheelchair bound or bedridden.
Okay, so in this case our child is disability scale എവിടെ വരും നമ്മുടെ കുട്ടി?
Now the child can walk with support. At presentation it was 4. Now improved to 3.
So he's improving. So now you know that child is improving. അപ്പൊ നമുക്ക് ആ ഒരു സ്കെയിലിന്റെ ഒരു അഡ്വാൻറ്റേജ് അത് കാണുവാണ് അല്ലെ? സോ ഡിസബിലിറ്റി സ്കെയില് അത് 3 ഇപ്പം. So at presentation it was 4. Now he's going to 3. Okay, disability scale. Okay. Now how will you manage?
Supportive management. For if there is any respiratory compromise, mechanical ventilation, then
1 is monitoring of the child.
Monitoring.
Any child with Guillain-Barré, he's at a risk of what all things? A child with Guillain-Barré, why should you admit? Will you admit all cases? Why should you admit?
Autonomic dysfunction.
Yes, good. Autonomic dysfunction and respiratory compromise. These two can occur at any time. So, even to mortality എത്രയാ വരുന്ന? GBS
less than 5%.
Less than 5% ആണ്. പക്ഷെ ഈ ഒരു less than 5% തന്നെ മോർട്ടാലിറ്റി വരുന്ന ഈ 2 കാരണങ്ങളാണ്. അതുകൊണ്ട് ആണ് നമ്മൾ അവരെ അഡ്മിറ്റ് ചെയ്യുന്നത്. സോ മോണിറ്ററിങ് ഇസ് ഇമ്പോർട്ടൻറ്റ്. എന്തൊക്കെ കാര്യങ്ങളാണ് നോക്കുന്നത്? ഒരു Guillain-Barré ഉള്ള ഒരു പേഷ്യന്റ് ഡയഗ്നോസ് ചെയ്ത ഒരു കുട്ടിയെ നിങ്ങൾ ദിവസവും നോക്കുമ്പം അല്ലെങ്കിൽ ICUയിൽ അഡ്മിറ്റ് ചെയ്ത് കിടക്കുമ്പോൾ എന്തൊക്കെ കാര്യങ്ങളാണ് നിങ്ങൾ ദിവസവും നോക്കുന്നത്? അല്ലെങ്കിൽ ഇൻ ബിറ്റ്വീൻ ക്ലോസ് ആയിട്ട് മോണിറ്റർ ചെയ്യുന്നത്? അതായത് എസ്പെഷ്യലി ഒരു പ്ലേറ്റ് ഓഫ് ഫേസ് എത്തുന്നവരെ വളരെ ക്ലോസ് ആയിട്ട് മോണിറ്റർ ചെയ്യണം. അപ്പൊ എന്തൊക്കെ കാര്യങ്ങളാണ് നിങ്ങൾ മോണിറ്റർ ചെയ്യുന്നത്?
Respiration, respiratory pattern, single breath count.
Good.
Then BP.
ഡെയിലി സ്പൈറോമെട്രി ചെയ്യാം എന്നൊക്കെ പറയുന്നുണ്ട്. അത് ചെയ്യാൻ പറ്റുമെങ്കിൽ ചെയ്യാം. ഓക്കെ. Blood pressure monitoring, because nowadays we have the multi-para monitors. അപ്പൊ അത് കണക്ട് ചെയ്യുക. Continuously we can monitor without any extra effort. Okay. Along with that, we have to SpO2 can be monitored. Multi-para is very useful for these children. So we can monitor BP, heart rate, as well as the oxygenation. Then we have to do the breath count. Then വേറെ എന്തൊക്കെ നോക്കും? സെൻസോറിയം ഒക്കെ നോക്കും, നേരത്തെ പറഞ്ഞിരുന്നു. പിന്നെ എന്തൊക്കെ ചോദിക്കും അവരോട്? പേഷ്യന്റിനോട് എന്താ
Bulbar weakness.
whether he can swallow,
He can swallow.
talk to them, whether there's any dysarthria. ഈ കാര്യങ്ങളൊക്കെ നോക്കുന്ന. കാരണം ഇതൊക്കെ വന്നു എന്ന് വെച്ചാല് പിന്നെ അഗെയിൻ അബ്ഡക്ഷൻ അല്ലെ, അപ്പർ ലിംബിന്റെ അബ്ഡക്ഷൻ, ഫ്ലെക്ഷൻ ആസ് വെൽ ആസ് അബ്ഡക്ഷൻ. ഈ രണ്ട് മൂവ്മെന്റ്സ് ആണ് പ്രധാനമായിട്ട് നോക്കുന്നത്. അത് അഫക്റ്റഡ് ആവുകയാണെങ്കിൽ ഒരു ഇംപെൻഡിങ് ഒരു ഡയഫ്രമാറ്റിക് വീക്ക്നെസ് വരാനുള്ള സാധ്യത ഭയങ്കര കൂടുതലായിരിക്കും ഉള്ളതാണ്. ഓക്കെ. അപ്പോ സോ ക്ലോസ് മോണിറ്ററിങ്, especially till the patient reaches the plateau phase. Okay. Then പിന്നെ വേറെ ഏതൊക്കെ സപ്പോർട്ടീവ് മാനേജ്മെന്റ്, ദാറ്റ് ഈസ് റിഗാർഡിംഗ് ദ മോണിറ്ററിങ്.
Supportive management and prevent infections, nutrition.
സപ്പോർട്ടീവ് മാനേജ്മെന്റ് എന്തൊക്കെയാ ചെയ്യുന്നത്? സപ്പോർട്ടീവ് എന്ന് പറഞ്ഞാല് if the child is having a respiratory insufficiency, you can
Mechanical
go for
ventilation.
assisted ventilation കൊടുക്കാം. പിന്നെ
Prevention of DVT.
Okay.
Bed sores. Prevention of bed sores.
അതായത് പൊസിഷനിങ് ഓഫ് ദ പേഷ്യന്റ്, അത് ബെഡ് സോഴ്സ് പ്രിവെന്റ് ചെയ്യാനും അതുപോലെ തന്നെ റെസ്പിറേറ്ററി ആസ്പിറേഷൻ, ന്യൂമോണിയ ഒക്കെ പ്രിവെന്റ് ചെയ്യാനും ഒക്കെയാണ് പൊസിഷനിങ്. പിന്നെ അറ്റൻഷൻ ടു ദ ന്യൂട്രീഷൻ. ഫോളോ ഗാസ്ട്രിക് ഫീഡിങ്, അതല്ലെങ്കിൽ അല്ലാതെ കൊടുക്കാം. പിന്നെ
then management of pain.
പെയിൻ എന്ത് കൊടുക്കും? പെയിൻ യു ഗെറ്റ് യൂഷ്വലി ഇൻ ദ ഏർലി ഫേസ്. അതിനെന്താ കൊടുക്കുന്ന പെയിന്?
Gabapentin.
NSAID കൊടുത്തൂടെ?
NSAID.
ഈവൻ NSAID വിൽ ഡു. അത് വെച്ച് പറ്റുന്നില്ലെങ്കിൽ മാത്രമാണ് നമ്മൾ ഗാബാപെന്റിനിലോട്ടൊക്കെ പോണത്. പിന്നെ then comes specific treatment.
Immunoglobulin. 2 gram per piece over 4 days or 5 days.
5 days. പിന്നെ
Then plasmapheresis.
ഏതാ കൂടുതൽ ബെറ്റർ?
IVIG.
രണ്ടും ഈക്വലി ഇഫക്റ്റീവ് ആണെന്നുള്ളതാണ്. അപ്പോ IVIG എന്ന് പറഞ്ഞാല് ലെസ് ഇൻവേസീവ് ആയിട്ടുള്ളതാണ്. പ്ലാസ്മാഫെറസിസ് എന്ന് പറഞ്ഞാല് കുറെ കൂടെ ഇൻവേസീവ് ആയിട്ടുള്ള പ്രൊസീജിയർ ആണ്. അതുകൊണ്ട് അപ്പോ യു ഗോ ഫോർ IVIG. യു പ്രിഫർ IVIG. രണ്ടും കൂടെ കൊടുക്കേണ്ട ആവശ്യമുണ്ടോ? എനി ആഡഡ് അഡ്വാൻറ്റേജ്?
No added advantage.
Studies have shown that there's not much, there is no added advantage in combining the two. You use steroids?
Not recommended.
Not recommended. Good. So only in the chronic thing you go for steroids. Okay. Then what about the prognosis?
Good prognosis. Most of them recover.
Most of them
by around
എത്ര പെർസെന്റേജ്? Complete recovery, because those are the concerns of parents. എത്ര?
80 to 90%.
അത് അഡൽട്ടിന് കുറവാന്നാ പറയുന്നത്. കുട്ടികൾക്ക് 90 to 95%. 90 to 95% they recover completely. But it will take time. It can take up by 12 months, 95% of them will be fully recovered. Okay. 6 to 12 months, 6 months ആകുമ്പോഴത്തേക്ക് 90%, 12 months ആകുമ്പോഴത്തേക്ക് 95% completely recover ചെയ്യുന്നതാണ്. ഒരു 7 to 8 weeks ആകുമ്പോഴത്തേക്ക് തന്നെ നല്ല ഒരു ഇംപ്രൂവ്മെന്റ്, അതായത് അൺസപ്പോർട്ടഡ് ആയിട്ട് വാക്ക് ചെയ്യാൻ പറ്റും എന്നുള്ളതാണ് പറയുന്നത്. ഓക്കെ, so these things you should be clear about, so that when you counsel the parents, you have to have an idea of all these things, because those are the concerns, whether this child will be able to walk, run, അങ്ങനൊക്കെയുള്ള അവരുടെ concerns. Okay. So now open for discussion. Mohandas sir.
I think Purushottam sir is,
Nothing more to add. Silva. Good, good discussed well. Anything does Srinivasan sir? I think Srinivasan sir is not there. Sushma madam? Madam is not there. Anybody else want to, any comments? Does Sulfi sir poyo?
sorry.
അറിയില്ലാന്ന് തോന്നല്ലേ? Okay.
സാർ ഉണ്ടല്ലോ.
Sulfi sir.
Sir,
Sulfi sir എന്തെങ്കിലും എക്സ്ട്രാ പറയാനുണ്ടോ?
ഉണ്ടാവില്ല. Thank you, Silva, Divya. And Dr. Bindu. Bindu ഒന്നും പറഞ്ഞില്ലല്ലേ? ബിന്ദു തുടങ്ങി. ബിന്ദു അവിടെ ഉണ്ടോ? ഡോക്ടർ ബിന്ദു? ഇല്ല.
I'm here, sir.
Any more
Not to
comments?
add. She has presented well and madam has discussed.
That's a wind up ചെയ്യാന്നാ?
wind up.
Okay, sorry for creating problem with my audio.
There was some problem with the audio and
There was some technical glitches, but that usually happens.
ഞാനിങ്ങനെ സൈഡ് ബൈ സൈഡ് ആയിട്ട് 3 സാധനങ്ങളാണ് വെച്ചിരുന്നത്. അവസാനം ഞാൻ പിന്നെ ഫോണിലോട്ടായി.
Last part was audible, very well audible. Initially problem ഉണ്ടായി. Okay, now good night, Dasai. Silva.
Okay, good night.
Thanks.
Thank you, Silva.
Good night.
Good night.